Today we're going to be discussing the benefits of straightening teeth with periodontal conditions. Obviously, we don't move teeth with active periodontal disease, but it will be really interesting, I think, for you to see what the benefits of aligning teeth and having the occlusion and the forces going down the long axis of the tooth and the impact it has on the periodontal tissue. My name is Dr. Nancy Ward. I've been in practice over 35 years, and very much a great part of my practice has been orthodontics. And this came about from my education at the Pankey Institute when we were with the interdisciplinary team and the orthodontist presented his cases. I went up to him afterwards and said, I'm a GP, I'm a restorative dentist, and how do I learn how to do this? And basically, and this is back in the late 80s, he said that you can't. You're either an orthodontist or you're a restorative dentist, but you can't do both. So what I did was take every single course out there that was available to GPs and learned orthodontics, and then I hired my orthodontist and formed a study club, and once a month for 3 years we met with him. And I learned all the basics of orthodontics. And when Invisalign came out, it was very easy to switch over. And in the beginning I would tell my patients, this is more complicated, and I'd like to try it with Invisalign, but may I have your permission to put brackets on if I can't get the results that I'm looking for? And what I found was I really didn't have to put brackets on teeth. I was able to achieve what I wanted with aligner therapy. And of course, this has improved year after year after year as the technology has improved with aligner therapy, but there really is not a case that I can't do with Invisalign. I have my mastership in the Academy of General Dentistry. I'm part of the faculty, lead faculty for the Pankey Institute, but also part of the faculty for Invisalign, and very involved with the Academy of Restorative Dentistry and the Pankey Institute. What we'll be covering today is the benefits of straightening teeth with patients with periodontal conditions. Also, why and how periodontal conditions improve when you move or straighten teeth, and why it's better to use Invisalign rather than brackets and braces on periodontally compromised teeth. Why tooth movement? There are everyday opportunities in the GP practice if you just focus on what you're looking in the patient and basically just sort of train your eye. Our training has been really heavy as general dentists in periodontal disease treatment and restorative, taking care of caries, rebuilding occlusions. But alignment has not been part of that. So what I'm going to encourage you to do is when you start looking at your patients, think about alignment as part of that initial process, because we're treating three things. We're treating periodontal disease, we're treating caries, and we're treating malalignment or occlusal disease. And all three are so important in the overall health of the patients. There's so many everyday opportunities for proper alignment in your practice. When you improve the periodontal health and occlusion, treatment of pre-restorative case setup, minimally invasive dentistry, I found over time if I align the teeth, the amount of tooth structure I have to remove to create an ideal occlusion is drastically minimized. It definitely improves the aesthetics of the patient's mouth, and you'll get very healthy referrals from your patients who are happy with what you have done for them. What we're going to focus on today is improving the health of the periodontal tissues with occlusal health. As I talked about before, it's a matter of just training your eye to see what's there. We see it all the time, but we're so focused on other things than malalignment. And sometimes we think, well, just a little malalignment is not a big deal. But if you think about what will happen over time with that patient, the malalignment will increase in severity with time. So if we focus on it in the beginning stages, we're going to be able to help improve the overall health of the patient. So the biggest thing we're talking about is horizontal forces versus vertical forces. And as we learned in physics, a more ideal situation is when forces go down the long axis of the tooth versus the vertical forces, horizontal going back and forth, which then impacts the bony structures, the gingival tissue, and impacts the wear on the teeth.
So here we have a picture of a ClinCheck. and that is the animation of the process for moving the teeth. So when you've lost a tooth, that's an ideal time to talk to patients about, we can restore the missing tooth with an implant and a crown and the existing bite, but we can try to prevent this from happening from other teeth by aligning your teeth properly. So what they'll do for the missing tooth, in this picture you can see it's a gray tooth. What I tend to do for posterior teeth is I don't put in a full ponic. I ask them to actually put in a half ponic. And this will enable the plastic to come down the distal of the premolar and the mesial and molar, which will aid in expanding the teeth in this area. So I'm going to play through the ClinCheck, and you can see we're going to change the arch from a very V-shaped arch with all the posterior teeth lingually inclined, and the expansion really consists mostly of uprighting the posterior segments. And one of the things I want you to note, and we'll play it again, as you upright the posterior segments, it gives you space to align the anterior teeth, and you can retrocline those incisors to create a nice U-shaped arch. So let's play it again, and I'd like you to look at what happens with the anterior teeth as we upright the posterior teeth. So we're uprighting all the posterior teeth. They were lingually inclined, and as we round out the arch, it's going to give us space in the anterior so we can align those incisors. And then at this point, the implant can be placed. And a lot of times I will do refinement after the implant's placed, just not moving anything in the posterior segment. Just if there's anything you need to tweak in the anterior segment, you can do that.
So why do we even bother? The consequences of malocclusion. And fortunately, over time, it has been documented in the literature the impact of malocclusion on periodontal and oral health, gingival recession, and infractions. It is shown that if preventing gum disease and bone loss should include recommending proper alignment, and just 3 millimeters of malalignment can increase host factors for periodontal disease. It makes it so much harder to clean, and prevention is just so important. We also know, and it's documented in the literature, that periodontal disease contributes to heart disease, diabetes, COPD, baby weight, and an elevated cholesterol, and so many other disease factors. And everything the literature talks about inflammation these days, the impact on overall health. So preventing gingival recession should include alignment. And we know with time, these non-carious lesions, as patients age, become difficult to clean and can increase the probability of having decay on the roots. We can prevent all this by just aligning the teeth and having the forces going down the long axis of the tooth. And again, we're preventing the non-carious lesions. And the theory of that is the tooth has flexure, and the flexure is cyclical, and then you lose tooth structure. And this is documented in the literature. So we're going to spend some time now going over some cases. And it's interesting, what I set out to do was create a good occlusion. And then what the benefit was, you will see what happens with the gingival tissue. So this is Charlotte. Charlotte's 28 years old, and she came to me because she didn't like how her lower anterior teeth were crowding. But she admits she didn't wear her retainers after she had orthodontics. And she was getting married in 12 months, so she wanted her smile to look better. So the diagnosis was she has slight anterior open bite from cuspid to cuspid, lower crowding, gingival inflammation on numbers 5 and 12. If you look at these photographs up close, you will see on number 5 and on number 12, the tissue just looks very, very strange. And it turned out she had a slight amount of calculus there, but not a lot. And if you look at the anterior teeth, you can actually kind of see the loss of some enamel. She was a severe class 2 div 2, which I learned later because her mother came in as a patient also. But it's impacting her overall periodontal health. And of course, what she was perceived, she didn't know there was anything going on with her recession, but her lower anterior teeth were what was her driving force. So her treatment consisted of the following: disease control, which is always done prior to movement of teeth, scaling and replaning, and we restored some posterior occlusal decay, Invisalign, bleach, equilibration, and retention. And what's really nice is you can actually use your Invisalign trays as bleaching trays. And if you have refinement, that's an ideal time to have the patient bleach their teeth while you're waiting for the refinement to come back. It gives them something to do, and they're just so excited when they see how good their teeth look after they've been bleached. So this is her before picture and her smile.
So here we have it, and I'll play it several times. What I have with this ClinCheck is showing that there's actually an anterior open bite. And by doing slight IPR in the anterior, you can close this anterior open bite. And if you remember on this case, because of the anterior open bite, the lateral forces were on the premolars, and there, with some inflammation, we got the recession in the first bicuspids on both sides. This was an old case. If I had to do it again, I probably wouldn't have any IPR, and I would upright the posterior segments a little bit, which would create more space for the anterior to align. So again, let's play through, and you can see when it starts, there's none of the anterior teeth touch, and we're retrocliding the anterior teeth so they touch, so that we'll have immediate disclusion in protrusive on the centrals, and lateral guidance, instead of being on the first premolars, will be on the cuspids.
And before retracted, and after alignment. And look at that the overall just gingival health has improved. You know, one of the things I do when patients are in treatment, I ask for their help, and I ask them if they could please floss their teeth to make sure the contacts aren't too tight, because if they're too tight, that may impede tooth movement. The reality of it is I'm asking them to floss so they can improve their overall health. But if you look at the gingival health and the tissue of the bicuspids, it is dramatically improved. My treatment plan for her for this area was to have gingival grafting. She moved before that was done, but in Charleston she was having that done. So here we have her before smile, and you can see in the transition, just a little bit made a huge difference in her after smile. So here's another case. This is a 15-year-old, I think he's 14-year-old boy. And if again, look at the gingival tissue. And it's bound, he had a very deep bite, but look at the bulkiness of the tissue around his anterior teeth and the lower incisors. And pretty much in this case, I don't care how well he cleans, and there was very little plaque there, the tissue's never going to look healthy. The other thing I want you to look and follow as we go through treatment, look at the length of number 8 and look at the length of number 9. Number 9 has experienced delayed passive eruption because as it erupted, it just was stopped by the occlusion of the lower anterior teeth. The other thing you could note on number 10, there's a fair amount of wear on the incisal edge. And he's class 2, div 2 in this area. And of course, when you look at the occlusals, you can see the lingualized premolar. His Panorex is pretty uneventful. He'll eventually have his third molars out. And here's the treatment sequence. He didn't like his smile. His mother for sure didn't like his smile. And his brothers had orthodontics, and now it was his turn. So again, we do Invisalign. The intention was to intrude the incisors, upper and lower, and align the posterior segments and distalize the posterior teeth to create class 1 occlusion. There were some elastics placed, equilibrate, and then Bavarian retainers.
So here we have Amelia's ClinCheck, and it's automatically set up. So there are a few things we're looking at here. He has a very deep bite. This took 30 aligners, and I'll play it through again. But what I want you to note, the ClinCheck doesn't have the availability to show any change in tissue, but look at the lower anteriors. They will be intruded, and the upper anteriors will be intruded and proclined. And you can see, you can't tell the tissue, but you can see in my photographs that the tissue tone improves dramatically in the anterior teeth. So let's play through for the first 30. And those little blue lines are root torquing. And what I have found with time, I no longer use those because I find more trouble with posterior open bite. So I ask in my clinical preferences, please do not use root torquing on the anterior teeth. So we'll play this again. So you get intrusion and proclination of the anterior teeth and some expansion in the posterior segments. And that's how you will get improved gingival health once you align the teeth properly.
These photographs were taken for the refinement. But already you can notice, look at the length of number 9, still shorter, but the tissue, although it's still bulbous, looks better, and same with the lower anteriors. We were able to get the lower number 20 in alignment. And one of the things you see, there is a slight posterior open bite. And this was because the upper anterior teeth were not proclined enough. They're still retroclined. And as we procline those teeth, it'll allow the posterior teeth to erupt.
So here we have Emilio's refinement, and I want you, and the movement, it's 16 aligners. You will see there's a jump at the end. The jump is because they can't show anterior-posterior changes or vertical changes, so they make it all as a jump in the back. So a couple things when you're looking at this. So the blue circles are cut out so I can put buttons on those teeth. I mostly use buttons and elastics versus the cutout for just to hook the elastic on the aligner, because I find the buttons are much more reliable. Sometimes, depending on the patient, the aligner, the hook will stretch out of position. The other thing on here, you can note that there's still the root torque on the lower anterior teeth, but I want you to carefully, and when you first look at it, what's nice about having ClinChecks, you can compare one to the other. If you remember, he had an extremely deep bite in the beginning. And look at the gingival height. You know, it has changed from the initial ClinCheck. So we're going to play it again so you can see the very first, that's the improvement in how much we accomplished with the first 30 aligners. And then it took 16 more to get the bite that I finally wanted. And here, see the bite? And then this is bringing everything together. So the ClinCheck, like I said, is a good way to see how your plan is working and then what you need to do to make it work better. The only other thing I would have done, if you can see, and it's, you know, when you look, I would highly encourage you to always look back at your cases and really study what could I have done differently. In this case, I would have done a little bit of interproximal reduction between the upper centrals and the lower centrals, so I could have made that contact point a little tighter. On the end photographs, you'll notice there's a little gingival embrasure. In the end, that ended up filling in. I don't have a picture for that because it took about a year. But just to not have that, I would have done a little IPR, and that allows you to bring the roots closer together so that the contact point is 5 millimeters above the bone, which we know in the studies that means the gingival tissue has the ability to fill into that spot.
These are the photographs after. And you can see, look at the gingival tissue. That's what I think is amazing. I mean, we didn't go out initially saying, oh, we're doing this because the gingival tissue doesn't look good. But the end result, when you let the forces go in the right places, the tissue just looks wonderful. And look at the length of 8 and 9. Nothing was done to number 9. It was not a gingivectomy. It just has to do with a proper alignment and moving forward with that. So again, we'll look at before pictures, look at the gingival tissue up close, and keep an eye on both the upper and lower tissue, and the dramatic improvement just by tooth alignment. And these are his before and after photographs. He was happy, and more importantly, his mother was very happy. Here we have another patient, Maggie. She's 68. Age really doesn't matter. The oldest person I've gone through Invisalign is 84 years old. And his motivation was he needed a crown redone on number 8. And he said, can you correct my lower crooked teeth? We said yes, and so we moved his teeth and replaced his crown. So her treatment plan was trying to solve her occlusal problem. And she had multiple fractured teeth in the posterior. She had just fractured off a lingual cusp of number 19. That often is just a great conversation piece. When someone breaks off part of a tooth, you can say, we have a couple options here. We can either repair your tooth, or we can try to take care of the cause of why it broke and spend some time talking about occlusion and the benefits of alignment. So this is an ideal time to bring up the topic for patients. She had wear on her maxillary incisors, pretty severe wear. She had rotated laterals, lingualized posterior segment. She had periodontal disease in her molars, 4 to 5 millimeter pockets with calculus and bleeding. And she had gingival recession predominantly on the right side and fractions on the right side. My treatment plan was disease control, 4 quads, scaling, root planing, Invisalign, bleaching, equilibrate, veneer 7 to 10, maxillary bite splint, and mandibular ethics. We'll talk about that. And restore the posterior segments and quadrants. And when all the restorative was done, then we do the Vivera retainers, which are Invisalign retainers that you scan or take impressions, and they will produce 4 sets of the exact same retainer for the patient. The benefit of this is that when they finish the 4 sets, you have their occlusion stored in cyberspace. So as long as they've been wearing the retainers, you can continue to order 4 sets of retainers as the other ones wear out. So here are initial photographs, pretty much class 1. What I want you to notice in these photographs, look at the right side we talked about. And obviously, it wasn't obviously to me an intent at the time. I didn't realize that we would end up having such a great benefit of the gingival architecture improvement until after the alignment was done. But the right side has significant recession and fractions. And you can see the wear on the incisal edges and pretty much a reverse curve to her smile. Her incisors are too short compared to her cuspids. And here are 2 occlusal views. Interestingly enough, when she was a grad student, she had gold foils put in her lateral incisors. But she has had these amalgams since she was in college. And if you notice on number 19, just the lingual cusp is what she fractured. So that was a good time to talk about aligning her teeth to prevent that. Her motivating factor wasn't that, though. Her motivating factor was she just really didn't like how her anterior teeth looked. Here's her Panorex. And obviously, we're not going to do anything about her third molars. It was just my job to inform her that they're there and that she should have updated Panorexes every 3 to 5 years, just to make sure there's no movement in those third molars. So this was my treatment plan. I did put her in appliance initially. I've kind of changed my way of doing that. What I will do now, instead of putting her through an appliance, is I'll use the aligners as an appliance. And I will put bite tabs on the cuspids to open up her vertical a little bit, and for the first 5 aligners. And if she has muscle pain or whatever, what I find is that tends to go away. And if it doesn't, then I'll stop and put her through aligner therapy. But a lot of times you don't need to do that. And then just continue on with alignment of teeth. We did quadrant scaling and root planing. We did Invisalign to aligner teeth prior to restorative dentistry. Porcelain veneers 7 to 10, and then restoring the posteriors in quadrants. And this was at her request. What's really nice is once you align the teeth, it makes the restorative work so much easier. And I always encourage the patient to have a quadrant done at a time so that we can build the teeth ideally in a segment. And then when she was completed, we did the Vivera retainers. So this was her ClinCheck, which is the digital image, and you can see that number 9 is shorter than number 8, and that's due to wear. And they're both shorter than the cuspids. So one of the things Invisalign is just wonderful at is placing the teeth gingivally where you want them to have a more aesthetic result. And you can see the upper anterior teeth, the gingival heights are not even. So these are in photographs, and obviously the aesthetics look so much better with the veneers on her central and lateral incisors. And one of the things that when I was doing the photographs afterwards is look at the gingival tissue on the right side. Just by aligning the teeth, how much healthier it is. There was a more significant recession especially on 30 when the teeth were malaligned. But by uprating them and putting the forces vertically down the teeth, it improved the gingival aesthetics. There was no grafting done here. And this happens time and time again with cases. And it's just because of aligning the teeth and getting the forces properly down the long axis of the tooth. So again, we're looking at all the gingival recession on the right side, and then afterwards. And you can see all the forces are going vertical, and there's a drastic improvement in tissue. And it's pretty uneventful. So thank you so much for going through this segment, and I hope you will also start noticing the gingiva before and after alignment of teeth. I think you're going to see the benefit in your own patients just by getting the forces down the long axis of the tooth. And I encourage you to take really good photographs and document it so you can show the patient just how beneficial it is to align teeth and share that with other patients. Thank you very much.